Welcome everyone to today's webinar, Learn the Latest in the Evolution of Minimally Invasive Spine Surgery. I am Angie Stewart with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. John Williams, MD, is a board-certified and fellowship-trained orthopedic spine surgeon, specializing in diseases and surgeries of the spine for Spine 1, a division of Ortho Northeast, and has over 30 years of experience in the field of medicine. A native of Sherman, Texas, Dr. Williams holds a bachelor's degree in biology from Wheaton College in Wheaton, Illinois. Dr. Williams completed his medical training at the Indiana University School of Medicine in Indianapolis, where he also completed his internship and residency in the Department of Orthopedic Surgery. Dr. Williams was board certified by the American Board of Orthopedic Surgery and is a diplomat of the National Board of Medical Examiners. He is a member of the American Academy of Orthopedic Surgeons, the Indiana State Medical Society, the American Medical Association, and the Fort Wayne Medical Society. He is also a frequent presenter at many national orthopedic conferences. At this time, I am pleased to turn the floor over to Dr. Williams to begin today's presentation.
Thank you and good afternoon. It's a pleasure to spend some time with you this afternoon. Thanks for logging on. Today we're going to talk a little bit about the oblique approach to the anterior spine. And as just we have relevant disclosures, I am a consultant for Camber Spine. This talk is designed really and directed at three types of spine surgeons. The surgeon that's already doing T-lifts but would like to move into the anterior space and address pathologies that simply cannot be completed from a posterior approach. The second group is for surgeons that are facile and comfortable doing direct lateral or trans-psoas surgeries, but would like to take the jump and move anterior to the psoas, so to gain all of the advantages of direct lateral surgery, but also add accessing L5-S1 as well as diminishing the neurologic issues from direct lateral surgery. And finally, this is a procedure or a talk for people already doing the OLIF procedure but would like to become more comfortable doing the access themselves, particularly at L5-S1. So unfortunately, I don't believe I have a pointer that works, but if you look on the left side of this slide, you see the various access points to the spine to get into the interbody space. And we're going to be looking for that window between the aorta and the patient's left psoas muscle. And this is what we want to achieve. We want to achieve a solid arthrodesis in the interbody space and do it through a minimally invasive approach to the anterior spine. And this is commonly being referred to right now as OLIF surgery, or oblique lateral interbody surgery. This is what you can achieve or accomplish in terms of relieving the patient's neurologic embarrassment. On the left side, you see a badly collapsed disc space with severe bony foraminal narrowing. And patients that have this pathology manifest symptoms of significant radicular low extremity pain. On the right side, you see that an OLIF procedure has been performed where an interbody spacer has been used to restore the space between L5 and S1, locked into place with an anterior plate, and you can see that the size of the foramen and the way it's been changed dramatically to give the patient indirect decompression. And then in patients that have an unstable segment, they're not good candidates for anterior-only surgery. You can apply posterior instrumentation with the patient in this lateral decubitus position from a single position, applying percutaneous screws to achieve posterior rigid fixation following your anterior interbody work. So let's talk a little bit about how we're going to get to where we want to be. If I had a cursor to point to you, I'd draw your attention to that midline raphe between the rectus abdominis muscles. And typically, if you're a supine, traditional, anterior spinal surgeon, you're going to approach the spine from that plane. But oblique surgery moves laterally. In fact, it moves lateral to the rectus abdominis, and you can see those that muscle plane demonstrated here, into the region labeled transversus abdominis here, such that you're not interrupting or engaging the midline structures of the abdominal wall. When we do this, we actually gain the advantage of using omental fat to keep us safe from the peritoneal contents. And we'll talk a little bit more about that later as we talk about the logistics of the approach. But here's what we're working to access. We're working to access the anterior lumbar spine so that we have a broad swath of workroom to aggressively address either deformity, degenerative change, working to restore anatomy, and relieve neurologic embarrassment in an indirect fashion. And you can see that to approach this area of the spine, we have, starting at the top of the image and then working towards the bottom, we have segmental vessels at every level, from L1, L2, L3, and down to L5. And then down at the L5, S1 level, we have a unique challenge of the bifurcation of the great vessels, such that typically we're going to work between that bifurcation to access L5, S1. When we get done here today, I expect that you should be comfortable with the knowledge of getting to that space. Now, for those of you that are traditional ALIF surgeons, you're used to approaching the anterior lumbar spine with the patient in a supine approach. This is a very telling cadaveric CT scan. And if you look at this computerized tomography, look at the left-sided image, and what's shaded in red is the peritoneal contents and what they do when the patient is in the supine position. The image to the right is the same cadaver positioned in the lateral decubitus position. And look how the peritoneal contents, with the help of gravity, fall away from our field of work, such that we're going to work between the iliac crest and that green shaded fashion. And I apologize. I just learned a few minutes ago that I don't have a pointer to work with to draw your eyes to this, but you just have to use your eyes to look between the green shaded area and the iliac crest on the right-sided image, and you see the corridor or the window that opens up when the patient's transferred into the lateral decubitus position. That's one of the key advantages of OLIF surgery over traditional supine ALIF surgery. And here's the corridor that you're going to work through. You can see it between the left psoas muscle and the aorta. You see a wide fatty plane, and this is the oblique corridor that we're going to enter and then enlarge to deliver an implant that's every bit as big as an implant that you could deliver with traditional supine ALIF surgery. A couple of preoperative planning issues we want to address. So looking at these images, I'm going to draw your eyes to the left-sided image, and you see there's between the pair of vessels, the common iliac vein and common femoral artery, there's a wide swath of adipose. And it's through this corridor that you can safely access L5-S1 in the bifurcation of the great vessels. Contrast this image with your eyes. Now move to the right-sided image. And if you note the spine at this image, you see that that's an S1 pedicle in the lower left of this image. So we're below the L5-S1 disc, and you see that there's a midline left common iliac vein. Very dangerous. So this should not be one of the first 20 cases that you do when you're accessing L5-S1 from an oblique approach. This approach is very doable. I'm going to show you a case a little bit later in the talk to show you exactly how to get past a midline common iliac vein, but not initially. Initially, when you begin your first several cases of accessing L5-S1 through an oblique approach, you're going to want to look for vasculature that's shown on the left-sided image here. Another potential pitfall of doing oblique surgery and accessing the anterior spine at L5-S1. Look at the left-sided image here, and look how there's an arrow pointing to a fat plane between the left common iliac vein and the spine. And when you see the rounded edges of that vein, you know that this is a vein that can be safely mobilized in vivo to access L5-S1. Contrast this now to the right-sided MR image, and look at the left common iliac vein here. You see that it's flattened against the spine, and you also see that there's no signal indicating fat between the spine and the iliac vein. In this case, you have to be concerned that the iliac vein may be adhesed to the anterior spine and may be in harm's way when you go to mobilize this and enter the L5-S1 disc space. So I'll show you another case a little bit later in the talk of how to safely overcome this. But you need to recognize this in your pre-surgical planning, the status of the patient's vascular anatomy, where it is, and the state that it's in, whether it's free of adhesions because of the fat you see around it or not. So let's talk specifically about positioning. And the interesting thing about positioning for the OLIF procedure is we're still in the infancy of positioning. Moving forward, I believe we need to develop tools to allow positioning that's more reproducible and safer, but right now we're using primarily 3-inch silk tape as well as just standard OR pillows. And what you notice on this, for those of you that are direct lateral surgeons, this lateral decubitus position is very similar to what you're used to, with the exception that the hip and the knee are in full extension. So for trans-psoas surgery or direct lateral surgery, we flex the hip and flex the knee in an effort to relax the psoas muscle and relax the lumbar plexus. But here, in OLIF surgery, we want to extend the hip and extend the knee, because what that does is move the lumbar plexus and the psoas muscle along with it. It moves them posteriorly, opening up that access channel that we were just looking at on the CT images. The advantage of this procedure over direct lateral surgery is that you can see when the hip and the knee are flexed fully, it adds lordosis to the lumbar spine. So already in our pre-positioning, prior to any incisions being made, we're working to add lordosis to improve the sagittal plane and the degenerative spine by the positioning for OLIF surgery. Another advantage of this procedure is that compared to supine ALIF surgery, you actually can mobilize the patient into more lordosis with them lying on the side than you can if they're lying supine. So I'm going to have you follow with me this patient's surgical journey. We're going to look at his imaging studies, pre-op planning, and then a video of this surgery here. It was performed about 1 year ago. And here you see my initials on this. We preoperatively, we're identifying the patient with the surgeon's initials and our initial entry site. So this tells you we're going to begin our surgery in the anterior portion of the lumbar spine. In this case, we're going to address the patient's pathology in a single position with a 360-degree fusion, where we then perform posterior instrumentation in this position. A few things I'd like to draw to your attention. If you notice, this is a very big man. He's a 240-pound farmer. You see that 125-pound circulating nurse behind him on the left-sided image. With this positioning, it's a little different than direct lateral surgery. You notice that the mid-tape fixation point is not over the greater trochanter, but it's in the mid-femur. That allows you good access into the L5-S1 disc space, which is something that's not an issue if we're doing direct lateral or trans-psoas surgery. Finally, you see that this patient's had previous surgeries. If you look at his midline of the lumbar spine, he has multiple previous surgical scars. So 240-pound patient, multiply operated lumbar spine. This is not somebody that you want to do open surgery on, and he's a perfect candidate for OLIF surgery to reduce his deformity, restore his neurologic anatomy, and then obtain rigid posterior fixation through a percutaneous approach in a minimally invasive setting, keeping him in a single position. Now you'll notice that he has his spinal cord monitoring needles in place. You can see them on the left-sided image in the popliteal fossa bilaterally. You can see them on the right-sided image over the greater trochanter. But for OLIF surgery, we don't use spinal cord monitoring for the anterior portion of the case. We have full muscle relaxation that allows the abdominal musculature and the peritoneal contents to safely mobilize to get to the spine, which is a bit different than direct lateral surgery. Then, as we transition from the anterior to the posterior portion of the procedure, we reverse the paralytic and allow spinal cord monitoring to safely place percutaneous screws posteriorly. Same patient, we're going to mark on the skin the discs that we're going to attack, and we're going to do that very similar to the way you mark the skin for transpsoas or direct lateral surgery. So we first get an AP fluoroscopic film to ensure that the spine's in neutral rotation, and then we move to a lateral, and if you look on the middle image, we've marked the disc spaces of L4-5 and L5-S1, and we not only the anterior and posterior portions of the disc, but we've carefully marked the trajectory of the disc in order to form our access points through the abdominal fascia. It is critical that our trajectory is lined up right now, preoperatively, so that the instruments and implants that we deliver can be delivered through the smallest soft tissue envelope possible. And you notice on the far right-sided image, we've drawn out the anterior superior iliac spine. That's the circle. The iliac crest goes superior and cephalad from this. The inguinal ligament goes medial and distal to the anterior superior iliac spine. And I've drawn out images of the two sensory nerves that are at risk with this procedure. The ilioinguinal ligament that typically tracks parallel along the inguinal canal, and then the iliohypogastric nerve. So, ilioinguinal nerve, iliohypogastric nerves. And the way we avoid injury to these two sensory nerves is to ensure that just be certain that our skin incision is at least 2 finger breadths anterior to the anterior superior iliac spine. Let's talk about the dissection. So once we've determined where we're going to make our skin incision and where we're going to make our fascial incision, such that our trajectory runs straight in line with the disc spaces that we want to remove and fuse, we're going to make a fascial incision over the abdomen using bovial cautery. And once we do that fascial incision over in the abdominal fascia, everything else done for this operation is done bluntly. And that is one of the critical ways that we avoid injuring any of the structures that may fall into harm's way during this procedure. So we use if you look at the far left image, I'm going to take my index finger, point it straight at the disc space that I want to get to, and I'm looking at my skin mark in surgery, and just gently perforate first the external abdominal oblique, the internal abdominal oblique, and the transversus abdominis, all 3 layers with my finger, going through bluntly and feeling that release where my finger falls into the omental fat. Once that happens, if you look at the second image from the left, you're going to roll your hand around, put the pad of your finger on the patient's abdominal wall, and gently, in a semicircular fashion, begin sweeping your finger back and forth, separating the omental fat from the abdominal wall, moving your finger right back to the iliac crest, finding the iliacus muscle on the anterior side of the iliac crest, and then walking your finger back onto the psoas muscle, which you see in the third image from the left. Finally, moving your index finger off the psoas muscle until you palpate the aorta, and then you know you're at your access point. Now you're ready to place your dilator under fluoroscopic guidance and your guide pin in the disc space, and begin your opening your exposure and preparing to do your discectomy. This little maneuver right over the psoas muscle is so critical, and all of you that are used to doing direct lateral surgery, doing XLIF surgery, you're familiar with this maneuver. But you walk your finger right down the abdominal wall. At L5-S1, you're walking right down the iliacus until you palpate the psoas. You sweep your finger from the lateral wall over the psoas towards the midline, moving the peritoneal contents with it. Gravity is your friend here because the patient's in the lateral decubitus position. Gravity is moving the psoas away from you, moving the peritoneal contents away from you as you roll over the psoas muscle until you get to the medial psoas. So let's talk about this particular case. The farmer that you saw prepared for surgery 3 slides ago. 74-year-old gentleman, has multiple previous back operations, now presents with back pain, bilateral leg pain. He's got significant degenerative pathology at L5-S1 in the form of a spondylolisthesis. He also has complete disc space collapse with bone-on-bone changes at L4-5. Here's imaging studies, and this is our preoperative plan where we're looking to see, is his vascular anatomy friendly or unfriendly. You see here at the L4-5 level, I'll draw your eyes to the left-sided image where you see 2 green lines showing the working corridor between the left psoas and the aorta. So now you see you have a nice, broadly patent working corridor to get your finger and subsequent dilator right down on the spine at L4-5. At the L5-S1 level, you see a picture that's very favorable to the surgeon. You see you could almost back up a Mack truck to this L5-S1 disc space because the right and left common iliac veins and right and left common femoral arteries are so widely spaced at L5-S1. So this is a perfect first 2-level OLIF case for a surgeon interested in learning to do this procedure. Here is his imaging studies of plane radiographs looking at his pre-op and post-op images, because this is what we're getting ready to accomplish in this surgical procedure. I'm going to draw your eyes to the left side. You see severe disc space collapse at L4-5, bone-on-bone changes, where there's been bone that's grown into the foramen at L4-5, causing severe bony stenosis. At the L5-S1 level, you see that there's a 6 to 7 millimeter spondylolisthesis of L5 on S1, and because of this, again, bony foraminal stenosis. Now, I would take your eyes to the right-sided postoperative image. At L4-5, you see he's got a tall cage that's restored the interbody space, in so doing, has restored the foraminal real estate to take the pressure off the L5 in L4 nerve roots. At L5-S1, you see a 12-degree lordotic cage that has nicely reestablished lumbar lordosis for this gentleman. So let's move now into a video. This is a video of this particular patient. I don't know if you have sound or not with this, so I'm going to narrate this because on my computer I don't have any sound with this. The audio has been turned off. So this is the same patient that you saw. You see the anterior superior iliac spine is noted with a round circle. The line above this is the iliac crest. The L5-S1 disc trajectory and position has been noted on the lateral fluoroscopic image. And with my eye, I'm drawing a straight line from L5-S1 down to my access point. At L4-5, same situation. I want to draw a line with my eye from the L5-S1 disc to where I'm going to make my fascial incision to approach that L4-5 disc. And in order to attack these 2 levels, I'm going to make a single skin incision in an oblique fashion, 2 finger breadths in front of the anterior superior iliac spine. And through this single skin incision, I'm going to mobilize the skin incision in order to gain access through the fascia, first at L5-S1, then at L4-5. 2 separate fascial incisions through a single skin incision. And I don't have a way to speed this video up. I wish I could, but I can't.
You could ask the moderator.
Moderator, if you could speed up this video just in the sake of saving some time, thank you. So I'm going to use a Raytech sponge. I'm going to pull the fat away from the fascia. I'm going to prepare, using my eyes, where I'm going to place my fascial incisions over the external abdominal oblique to make sure my trajectory runs straight into first the L5-S1 disc, then the L4-5 disc. So and this will be the last sharp dissection that you see in this procedure. We're going to make a fascial incision straight in line with that disc from L5-S1. And the incision doesn't need to be any more than 4 or 5 centimeters in length. We'll make a similar fascial incision, but that will be up to the left side of the skin incision to address L4-5. So here you see the fascial incision has been made in the abdominal fascia. You see the red of the external abdominal oblique just beneath the fascia. And I'm going to use my index finger. I'm going to point right at that L5-S1 disc. And I'm going to just gently going up and down, getting between the fibers of the external abdominal oblique. I'm going to begin to access that omental fat and develop the retroperitoneal space. You'll feel yourself pop through each level, the external abdominal oblique, internal abdominal oblique, and transversus abdominis into the retroperitoneal space, which feels very soft. And here again, gravity is your friend. It's pulling the peritoneal contents away from out of harm's way. And now you see, once we're through that muscle, you see that yellow fat that indicates that we're in the retroperitoneal space, the mental fat. So now, right there, what I'm going to do is I'm going to take my distal interphalangeal joint in my finger. I'm going to roll it up underneath the abdominal wall, and I'm going to begin to separate the omental fat from the abdominal wall. The peritoneal contents fall away with gravity. As we do this, I'm going to keep working my finger north and posterior, and that keeps me out of harm's way. I'm going to go ahead and develop my space over the L4-5 disc space access right now. You can see my finger underneath that spot we've marked for L4-5. And once I've freed the omental fat from the abdominal wall, now I can use my fingers to enlarge my muscular opening in the abdominal wall. And in what you see here, I'm not doing anything sharply. So there's no way for me to transect the ilioinguinal nerve or the iliohypogastric nerve. With this complete, I take my fingers, I palpate along the iliacus, the psoas muscle, and right down onto the common femoral artery. And once I feel that left common femoral artery, now I can move my finger onto the sacral promontory. The sacral promontory, it tells me that I'm on the midline at L5S1. But remember, while you can feel the left common femoral artery because of the pulse, you cannot feel the left common iliac vein. So here's a couple critical steps. You're going to use a lighted vascular retractor. You're going to walk it right down the back of your finger and dock it on the spine. Your assistant standing on the other side of the table, my surgical scrub tech, is going to place a hand on the patient, hold the retractor, and they're not going to move. And what I've done is I'm for sure protecting the left common femoral artery, but I want to find that left common iliac vein to make sure I don't harm it. The lower blade, again, it's another lighted retractor blade. The lower blade is a Homan blade that is designed to slip on the far side of the spine, protecting the right common iliac artery and right common iliac vein and right common femoral artery. Here I'm going to use an endochitner to gently mobilize the prevertebral fascia over the sacrum. And if I'm never certain where I am, if I'm ever wonder where I am, I'm going to go down on the sacrum, make sure I'm distal to the L5S1 disc so that I know I'm going to stay out of harm's way in terms of the vasculature. Once I have seen the left common iliac vein, I know it's behind that upper vascular blade. Now I'm going to pin that blade to the spine, and I'm going to do it with a threaded pin to suck the blade down onto the spine, and now everyone can breathe a big sigh of relief because that left common iliac vein cannot get into my surgical field. It's safely out of harm's way. And I'm going to check that pin myself to make sure the blade is secured to the spine. This is a fluoro image just showing the pin in the sacrum. That pin is through that first vascular blade. There's a pen field on the L5S1 disc space because you're going to want a blunt dissector. And now I'm going to place a pin into that vascular blade and lock that vascular blade to a table mount retractor. Next, I'm going to ensure that my middle sacral vessels are identified. I'm finding the middle sacral vessels right now with my pen field. You can easily see them just by mobilizing them back and forth using the endochitner and the pen field. And I'm going to ligate those using bipolar electric cautery. So once I've ligated and transected the middle sacral vessels, now we're ready to get after our discectomy. So you can see a Homan blade that's down towards the floor, a bifurcation blade that's been set to protect me from injuring the distal aspects of the vena cava or aorta. And now I can take my long handled blade, this is an 18-inch blade, with a 15 number 15 scalpel blade at the end of it. So 18-inch handle, 15 blade, and do my anterior annulectomy. And once that's complete, I am ready to perform my discectomy, starting first with a cutting cob. Let me show you another advantage of this procedure over a supine ALIF. Watch how easy it is to get a fluoroscopic image while I'm working, which you simply can't do when you're doing a supine ALIF. We've set our trajectory properly so we can get straight instruments right into the disc space. And now I'm going to check a fluoroscopic image because I want to work all the way to the back of the disc space to the spinal canal. So, moderator, if you could bump up the speed of this video again, I'd appreciate it. And we'll get to the end of this surgical portion. So we'll just touch on what we're doing here. So, sharp cob elevator, now an angled curette. This is almost identical to doing an ACDF surgeons, where you're going to take this angled curette, go to the back of the disc space. You can see that curette at the back of the disc space. I'm going to go all the way to the spinal canal, take out the posterior annulus, and in fact, even take out the posterior longitudinal ligament. So I've got a wide posterior decompression, wide foraminotomy, using that angled curette. Now I'm going to show you just what it looks like fluoroscopically to size this. You can really use fluoroscopy in this position to get a beautiful sizing guide at L5S1, because this is critical to accomplishing indirect decompression and staying out of the spinal canal. So this is what you can do this in a lateral decubitus position, but this is very, very challenging to do when the patient is positioned supine for traditional ALIF. And then we're going to use our bladed retractors to move to the L4-5 level. Here you see the inner body implants at L4-5, L5S1 with an anterior plated L5S1, restoring the inner body space at L4-5, reducing the spondylolisthesis at L5S1. Final step in the procedure anteriorly is to take our blades out the exact same way we went in. So we're gonna slowly walk them out. I say chopstick them out using these lighted retractor blades. I'm looking for any bleeding, and truly, when this procedure is done correctly, I mean, a 50 cc blood loss in this procedure is unusual. It's most of the procedures that we do in this oblique approach are just as dry as what you saw on this video. So now there's no bleeding. It's time to close this wound. We're going to close the musculature with the running vicryl, the fascia with the looped 2L PDS. Now my assistant's closing the anterior wound on the right. I've walked around. I'm standing on the patient's posterior side, placing percutaneous wires. In this case, I used a single midline incision because the patient had a scar there. Many times I'll use bilateral Wilts incisions, but here there's a midline incision. Do the guide pins and screws on one side, then the other. Here you see the anterior wound that's been closed. Here you see the posterior wound that's been closed in the midline. Operation is done, single position surgery, anterior, then posterior surgery. So let's move forward. I'm going to show you some cases here that I think you'll find interesting. This is a case of a 35-year-old nurse. Her BMI is 40, so a rather large girl. She's had multiple L5S1 discectomies. So she's 35 years old, has this bone-on-bone configuration, 5-1 disc space. And what we're going to do is her pre-op film is on the right, her immediate intra-op, post-op film is on the left, where a SPIRA cage has been placed to restore her inner body disc space. But the reason this case is interesting, I'm going to show you right now, is look at the vascular anatomy in this patient at L5S1. So if you look with your eye to the right side, you see the sagittal image showing where the axial cut is. Move your eye over to the left, move anterior to the spine itself, look at the vasculature, and you see that the left common iliac vein crosses the midline. It's on the right side of the spine. So you look at this and you say, oh, this looks very dangerous. And you're right. This is something that has to be approached with caution. But we start distal. Go down, go distal on the sacrum, work up on the sacrum, and just show you what it looks like. So if you move down, you see the left common iliac vein begin to move to the left. Here it is at the distal aspect of the disc space L5S1, but still that vein is still in harm's way. So you're going to begin your dissection down on the sacrum, work cephalad, and using your endokitner to carefully move that left common iliac vein out of harm's way so you can place that the metal cage you saw just a moment ago. Another interesting case, just to bring to your attention, this is another lady whose BMI actually is 45, so really a challenging case. She's had multiple previous operations. You see her L5 lamina is gone from multiple previous discectomies, so she has no disc left at L5S1, severe collapse at L4-5. If you look here, she's got a recurrent disc herniation at L4-5. But look right here. If you look up and to the right on the left-sided image, you see she's got a wide corridor to access the L4-5 disc space. And here's what can be done with this lady with this new retractor system using independent vascular blades that are lighted, giving the surgeon the freedom to develop the space in a minimally invasive way. And here she is, single position surgery. The posterior instrumentation has been applied in the middle image, and there's an AP image on the far right with the final picture looking at interbody implants and posterior instrumentation. But I just want you to see this lady and just kind of see what you can deal with. These are 16 centimeter vascular blades. I wish I had a pointer here to point this out to you, to those of you watching, but there's 3 blades at L5S1. There's a lighting source allowing you to light your retractor blades to find your way down, and look at the size of this patient's belly. A BMI of 45 is something that I can't imagine trying to do this operation with the patient in a supine position. But because the patient is in an oblique position, you see that her peritoneal contents fall out of your way, and you can safely access L5S1. Here, using the same, this is the retractor system that's being developed by Camber. It's got lighted retractor blades. Here, the blades have been, the blade handles have been removed from the blades after the blades have been placed. And if you can use your eye and imagine, there is a novel and unique device allowing you to connect the 2 blades together. And this retractor system is referred to as a blade-to-blade retractor system, novel and unique on the market right now. You also see that it's locked to the table with a table mount, so you get rigid fixation. You'll also see that there's threaded pins that go through the blades, locking the blades to the spine. Here's an artist rendering of this. It makes it a little easier to see. Look at the L5S1 disc space on the left side of your image. You see that the upper blade has a pin locking the pin to the S1. There's a bifurcation blade, blade number 2, holding the aorta and inferior vena cava out of harm's way. And then the lower blade, or blade number 3, a Homan-style blade, goes under the spine, keeping the right common iliac and right common femoral vessels out of your way. If you look to the image on the right, you can see how the connectors work, locking the blade-to-blade flexible arms from one blade to another. And then once these 3 blades are locked together, eyes back to the left side, please, you see that the 3 orange handles can be removed, so you have easy access to move your fluoroscopic C-arm in and out. Here's the same retractor shown at L4-5. In vivo with that heavy lady, the lady with a BMI 45, I only used a 2-blade retractor system. But this retractor system has endless options. You can do a 2-blade, a 3-blade, or a 4-blade configuration. You can certainly lock the retractors to the table with the table mount using either 1 or 2 table mounts. And then each blade can be locked to the blade next to it using the blade-to-blade connectors. Really clever and something that can absolutely change your life if you are dedicated to operating on the anterior lumbar spine. Just a final image showing that you can even have a 4-bladed retractor system if you desire, placing each retractor blade with the handheld device on the blade, then locking the blades together. Once the blades are locked together and pinned to the spine, you can remove the orange handles, again, making your ease of work around the spine easy to manage. So we've talked a little bit about access. We've talked about the retractors they're underdeveloped right now. All of this it's critical also to have instruments that allow you to go down this very small soft tissue envelope to the spine and do what we want to do, a complete and entire discectomy, decompressing the spinal canal, decompressing the foramina bilaterally, and achieving a solid and robust interbody arthrodesis. Well, in order to do that, I'll take your eyes to the image on the left. Look at the angled bend of that cutting cob, and you see that 60 millimeters away from the tip of that instrument, the instrument's been bent 20 to 25 degrees, and it allows you to work through this oblique trajectory, get into the disc space, but clear the disc to the far side of the disc, transecting the annulus and mobilizing that interbody space to reduce deformity, to restore interbody alignment, and thereby relieving neurologic embarrassment. If you see the Homan blade that's protecting the vasculature and to the spine, and you can easily take down the anterior longitudinal ligament if you want to add a hyperlordotic cage to really aggressively add sagittal alignment to the spine from this approach. So, inserting a 20 or even 30 degree hyperlordotic cage is very straightforward as long as two things are accomplished. You have the instruments to do the discectomy, and then you have the inserter to place the implant. And in this case, it's nice having implants that are built from the ground up with 3D printing to insert a cage through this oblique trajectory. Here you see an inserter that's a straight inserter, but the cage has been designed to deliver a robust lordotic cage into the interbody space, filling the space to achieve great end plate coverage, but doing so through an oblique approach. If you find that your trajectory is a little off, you can use an adjustable inserter, which is available right now, same implant, to get into the interbody space to the trajectory that you've developed. Let's look at our time. How are we doing?
1:43.
Okay, let's talk. I'm talking a little bit about complications, challenges, and I would like to touch on some biomechanics and basic science for achieving what we want to achieve here: restoration of anatomy and a solid arthrodesis. Well, as you're aware, the vascular challenge for this approach is really what everyone thinks about. And I will tell you, the best way to stay out of trouble, always know where you are. Always know where you are. And if at any point during that dissection that we went through, if I find myself in a situation where I'm not certain where I are, then I back up a step. If I still don't know where I am, I back up 2 steps and restart that process of getting through the abdominal wall, staying on the abdominal wall, letting the peritoneal contents fall away, getting down onto the psoas muscle, and finally onto the spine. That is how you know where you are and you know where the vasculature is. And then I would just encourage you, get a hold of this retractor system that has these independent lighted blades to keep you safe. And this is something that to learn more about this, we'll have to do this online, which you can certainly do by contacting a gentleman by the name of Seth Anderson at Camber. If you want to learn more, to get on their teaching group, this company is committed to teaching surgeons to do this well. And they've got as soon as we get through this COVID situation, teaching sessions around the country for you to attend. Neural complications for this oblique approach are minimal. You don't see the neurologic complications that you see when you're working in a trans-psoas position. The biggest neurologic complications that I've seen are irritation of the nerves that run along the inguinal canal. That inguinal ligament is something that when you retract on it, it can leave patients with a sore groin or testicular pain, something that we treat with simply ice and anti-inflammatories. But as long as your dissection is blunt dissection, those symptoms go away. And so to avoid injury to the ilioinguinal nerve and the iliohypogastric nerve, keep your dissection blunt after you go through the fascia. Can't say that enough. Other potential items that might fall into harm's way, the ureters, when you see them, and you will see them, always make sure they stay with the peritoneum. So let the peritoneal contents fall away, keep the ureters with the peritoneum. To avoid bladder injury, always make sure the patient has a Foley anchored. That'll keep the bladder decompressed. And really, injury within the abdominal contents is very difficult to do as long as you're allowing gravity to work for you. Tips and tricks. Just be prepared for blood loss. I've not seen any blood loss that I can't handle myself. So I'm not, I think it's great to learn this procedure with an access surgeon, but it won't be long before you just don't find the need to have an access surgeon. The things that you can do to save your hospital system money and to save time is learn this technique of single position surgery. And you can even do simultaneous position surgery. If there's two surgeons in the room, you can have a surgeon operate doing percutaneous screws in the back, posteriorly, and doing anterior surgery in the front. But what I'm doing right now is I call it single position surgery. I do the anterior portion of the procedure, then I transition around, stand on back, do the posterior portion of the procedure, and it keeps the staff moving forward in an effective fashion. A little bit about biomechanics and the bioscience behind this. You know, these cages that are designed specifically for interbody work in the oblique space are something that I can't say enough about. It's not enough to take an OLIF cage or a lateral cage and try to modify an instrument to put a cage in. You need to have a company that stands up next to you and is developing implants and then the instruments to go with them to develop good devices to the interbody space. And take a look at this one. This is one built using 3D printing so that you allow this roughened surface throughout the cage. You basically have the entire cage as part of your fusion bed. When you're doing 3D printing, additive manufacturing development, you do not carve into the surface of titanium. So this metal is not cut on. Therefore, it has very little wear debris. The risk of wear debris is essentially zero with this form of manufacturing. And the other advantage, I'm sorry, I lost my train of thought. I'm trying to speak so quickly, is with this arch design, you're distributing stresses across the interbody space throughout the implant, not just on the surface of the implant. And what that allows is, because the arches are throughout the implant, this implant is not a donut. You see there's no big hollow opening in the implant. The stresses in the interbody space are distributed throughout the implant, not just on the rim, but throughout the implant. But this is done without compromising your bone graft. 75% of this implant is still air, so you can still have plenty of room to pack your DBM or your BMP or your allograft to get a solid arthrodesis. And the beauty of these arches is that as the implant settles, even 0.5 millimeters of settling increases the surface area where the implant's contacting living bone by more than 50%. So the biomechanics behind these implants are impressive. A note about the biomaterial in the biologics. You know, we know that the surface bone loves to grow on is the surface that's roughened with a 500 micron surface. But this is a hard surface to apply with a spray or to apply later to a solid piece of PEEK or titanium. What we found is to apply the perfect randomized 500 micron roughened surface, it needs to be done with this additive manufacturing or 3D printing. And this in vitro biologic study done at the Hospital for Special Surgery has shown that bone and bone cells love this roughened surface to begin the initiation of first attracting mesenchymal stem cells and then inducing or encouraging those mesenchymal stem cells to transform into osteocytes and osteoblasts. So in conclusion, surgeons that know the value of working in the anterior space in the anterior lumbar spine, the oblique approach offers you all of the advantages of a supine open ALIF and all of the advantages of direct lateral transpsoas surgery without the complications of those surgery. You don't have the peritoneal and urologic complications that you have with direct anterior surgery, and you don't have the neurologic complications and the psoas damage that you have with direct lateral surgery. So this oblique approach to the spine is something that is to be explored for any surgeon committed to treating pathology in the anterior approach. And with that, I would say that I'd love to take some questions. If there are questions out there, the final case I'd show you is a great first case for surgeons that are looking for, okay, what do I want to look for my very first case to do OLIF surgery, perhaps even OLIF surgery and do posterior instrumentation in the single position, leaving the patient in the lateral decubitus positions. I'll show that unless there's any questions that I can address right now.
One. How do you do?
Excellent. Thank you so much, Dr. Williams, for that fantastic presentation. And we will now begin today's question and answer session. So audience members, please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we will try to get through as many questions as we have time for by the end of the hour. So we have quite a few questions already coming in here. I'm going to go ahead and start with one. Sorry, what was that, Dr. Williams?
Oh, I just noticed a question popped up. It's a great question. How do you do kyphosis correction surgery? Okay, now this is a broad question, so I'm gonna try to tackle this. It really depends. Are you talking about segmental kyphosis, where there's been a fracture and there's one vertebral body that's kyphotic, or is this a global kyphotic surgery? Most of the kyphotic surgeries that I'm seeing are usually you want to find the apex and go there first. And being able to get to L5-S1 is always helpful, because that is the most effective way to add lordosis when you're trying to restore coronal balance. But if your kyphosis is at the thoracolumbar junction, you want to go there. You can still use same retractor system, same implants. This company happens to deliver a lateral implant that you're going to want to use at T12L1 and L12, but you approach that direct lateral, sweep your diaphragm anterior, work to stay retropleural, and treat your kyphosis first with an anterior release if need be, and then move distal to that. And certainly in kyphotic deformity that's in need of sagittal realignment, addressing L5-S1 is critical. So you want to get down to L5-S1, use a 15-degree lordotic implant or 20-degree lordotic implant in an effort to do this. Average length.
Excellent. Thanks for touching on that. Yeah.
You bet.
Average length of procedure time, if you could expand.
Yeah, it varies certainly based on the patient's body habitus and how many levels we're going to do. But for a single level, let's say for those cases I showed early on that are anterior only, so the spine is stable, and you're going to do it L5-S1 only with an anterior plate, the operation is about 90 minutes or less. If you're going to do a single level L5-S1 with posterior instrumentation percutaneous, then you would add an hour to that. So about 2 hours to 2.5 hours to do a single level. Then, of course, that time goes up if the patient is heavier, just because the approach takes a little bit longer. You'd be a little bit more careful. I'll start jumping down to these questions unless you have one you really want me to go to.
No, absolutely. Go ahead and speak to the ones you feel most equipped to answer, and then I'll let you know when we're getting towards the end of our hour.
Yeah, you got it. There's a good question about complex surgery here. Do you use this approach for corpectomy surgery? I do a lot of corpectomies, either for tumor or for trauma, particularly tumor. When I do corpectomy surgery, I still stand to the patient's posterior side. I don't stand anterior, and I do more of a direct lateral approach where when I get down under the psoas, I still take my Cobb elevator, mobilize my psoas posteriorly, but I'm standing on the patient's posterior side when I'm doing corpectomies, L4 and up. L5 corpectomy is a totally different animal. We won't try to tackle that one here. Are there any special considerations or challenges for plate placement when using the OLIF approach? That is a great question. Okay, I'll tell you why. The guy that asked this question has already placed a bunch of plates with open supine ALIF surgery. Listen, when you place the plate from an oblique placement, you have to have a universal screwdriver. You have to have a universal screwdriver with a universal joint. Let me say this clearly. So that the universal joint is just off the tip of the screwdriver, allowing the handle of that screwdriver to move out to the oblique corridor. I think it's very important as we talk about OLIF surgery, the oblique approach to the lumbar spine. We don't want to use straight instruments where we have to do an orthogonal maneuver and then we dramatically push against our soft tissue envelope. You want instruments that are designed specifically for OLIF surgery, and that's why you need to come up alongside a company that's focused on this pathology and this treatment program. So yes, there are good plates available, but they need to be plates that you can address your screw fixation with a an offset screwdriver with a universal joint in the distal extent of the screwdriver? Great question. Do your single-level anterior only patients go home the same day? You know what? It's just in my last probably 6 months. I've been doing this operation now for about 4 years, and it's just in the last 6 months that I've had a couple of patients that insisted on going home the same day. I usually try to keep people overnight just for observation. I want to say hi to them the next day. I would say easily 50% of all of these cases, even two-level anterior-posterior cases, could go home the same day. I keep them all overnight just for observation and say hi to them. But single-level anterior-onlys, for sure, those people are up running around the same day of surgery. They're in their brace, walking in the hall, same day. Average length of stay in the hospital, it is rare for them to stay more than 1 day. I have everyone spend the night. I want to make sure they don't develop an ileus, make sure they're eating, drinking, no nausea, comfortable. So average length of stay in the hospital, I would say the average length of stay is probably 1.0001 day post-op. Very rare do they stay more than 1 day. And that's going to be the elderly patient, 3 or 4 levels, someone where I really had to do maybe an anterior osteotomy in order to reduce a rigid degenerative situation. So they're sore, they'll stay 2 days. I've never had anybody stay, I shouldn't say never. It is almost unheard of for a patient to stay 3 days in the hospital after this procedure. I've got a question here. How do you code for this procedure? It's just ALIF. It's just an ALIF procedure. You're working in the anterior space. You're looking directly at the anterior spine. If you want to take down the ALL to further mobilize the spine, you can. If you want to maintain the ALL, I'll tell you, I like maintaining the ALL above L5S1 because then when you put a robust cage in the interbody space, you're levering against the ALL and really opening the posterior interbody space and improving your neurologic embarrassment relief. So by leaving the ALL in place, putting an enormous cage in, you have a nice anterior tension band that allows you to open the posterior foramen and the spinal canal. But taking down the ALL it's very easy. I always take down the ALL at L5S1. In my opinion, you can't operate in that space, put in a nice, robust lordotic cage without taking the ALL down at L5S1. But above that, you certainly can take down the ALL at L4-5, L3-4 if you want to use a hyperlordotic cage, but I'm trying to maintain it. Anyway, that was a long answer for that question. I bill it as an ALIF because you're working in that space, and you can do just about anything you want to in this space as long as you learn to position the patient well on the table and then get your trajectory set correctly.
Dr. Williams, this is Angie Stewart from Becker's Moderating. I wanted to jump in here and say we're hitting the end of the hour and give you a chance to add any final thoughts. Thank you so much for rapid firing through those questions. It was really awesome. And if there's anything else you'd like to add before we close out today, I'll give the floor to you again.
Yeah, just in closing, I will tell you this. This procedure has changed my practice, and I am passionate about it. And it's been a thrill finding pairing with a company that wants to make this a priority because I am passionate about this. If you're interested in learning more about this or even visiting me here at Fort Wayne, because we have an orthopedic hospital where I can get you credentialed and you can actually scrub in surgery with me, do that through Camber Spine. Talk to Seth Anderson. He is outstanding at organizing people. This company is committed to teaching if you want to learn. So it's just been a thrill being involved with him. I can tell you that.
Fantastic. Thank you so much, Dr. Williams. Your passion, like you said, and your expertise has been extremely evident through this webinar, and I speak for Becker's and our audience members. Thank you for such an excellent presentation. And thank you to Camber Spine for sponsoring today's webinar. I hope you all enjoy the rest of your day, and we look forward to having you join us for future webinars.